Hello, today we are going to see about the development of temporal bone and its surgical importance. So, temporal bone is an amalgam of bones. So, it is made of 5 bones: squamous, tympanic, petrous, mastoid and styloid. So, all these bones has a different function. A squamous bone forms a tympanic bone. There will be a styloid process, that is styloid bone. Within this, here it is mastoid bone. Inside there will be petrous part of the temporal bone. The petrous part of the temporal bone is not visible outside. All other bones are visible outside. So entering into the development of temporal bone, the development of temporal bone is not a single mechanism. That is, it has both intramembranous and enchondral ossification. So first let me explain what is intramembranous ossification and what is enchondral ossification. So it is simple. So we used to do what our seniors have done previously, right? So similarly, if previously a cartilage rest is formed, from the cartilage rest a bone is formed, means that is enchondral ossification. If a bone is directly formed without any precursor, without any previous experience, with a small membrane will itself form a bone by itself, that is intramembranous ossification. So our temporal bone develops by both these methods. So it develops from 8 ossification center, 4 for the petrous and mastoid, because petrous and mastoid develops together. So together petrous and mastoid has 4 ossification centers, styloid has 2 ossification centers, squamous 1, tympanic 1. Entering into, so which are all enchondral ossification, which are all intramembranous ossification, let's see. So most importantly, squamous and tympanic part are from membranous ossification. They don't have any precursor cartilage rest. They develop directly. Okay. All the other 3 bones, petrous, mastoid and styloid, all these develop by enchondral ossification. They need a precursor cartilage rest, out of which a petromastoid has a precursor cartilage rest of otic capsule. A otic capsule will be formed by 20 weeks only. So once otic capsule is fully formed till 20 weeks, after that only petrous and mastoid part will start developing, and they will be having rapid development from 20 weeks to 24 weeks. In the meantime, there will also be development of bony labyrinth and other important structures of inner ear. So our styloid process develops from second pharyngeal arch cartilage, that is Reichert's cartilage we used to call. So these 3 bones develop by enchondral ossification, those 2 bones develop by membranous ossification. So we will say about petromastoid. So as I already said, 20 weeks it develops from otic capsule. From there onwards till 24 weeks there will be rapid ossification. Bony labyrinth will also develop from these areas. Squamous and mastoid part, so these develop directly by membranous ossification. They start from 9 weeks, and mostly the squamous part will reach its proper shape by 29 weeks. That is, it will form a tympanic ring. So the tympanic ring is the basic structure for our ear, right? So that will be formed by 29 weeks, but mastoid will not be fully grown till birth also. After birth only mastoid process will be fully formed. It will take at least 6 years for full development of mastoid. The pneumatization also takes 6 years of age to fully form. So that's why within the 6 years, if the pediatric age group patient is repeatedly having upper respiratory tract infection, means that hampers the development of the mastoid in a proper way. So that child will be having a unsafe type or aticoantral type of CSOM at later stages. So styloid process, as I already said, Reichert's cartilage of second arch. So it will fuse with the aortic capsule only at term. The surgical importance of the temporal bone. So important things are Mcewens triangle. So Mcewens triangle is for identification of mastoid antrum. So Donaldson line and Trotman triangle. So first of all, as I already said, mastoid process is not fully developed in children, so cannot be palpated. So it cannot be palpated at term. But in adult, we can palpate the mastoid antrum during the surgery like cortical mastoidectomy, modified radical mastoidectomy. We should be palpating the mastoid process. So if mastoid process is not fully palpated, we can't locate the exact area for identification of the mastoid antrum. So again, the adult will be having the facial nerve entering the or exiting the ear from stylomastoid foramen. But if mastoid process is not there, means so the facial nerve will be very close to the incision we are making. So that's why in normal adult we will be having a post-auricular modified William Weld incision. Okay, but in a child undergoing cortical mastoidectomy, the post-auricular incision must be given more horizontally. That is the surgical importance of mastoid process development. So next, Mcewens triangle is actually a triangle over the mastoid process. So here there will be a line drawn along the linea temporalis superiorly, a line drawn along the posterior external artery canal, and a line joining these two. This is our Mcewens triangle. So using the Mcewens triangle, we can reach the mastoid antrum, which will be approximately 1 centimeter beneath. Surgical mastoid. So the identifying the mastoid antrum is the first step in most of the surgeries. Cortical mastoidectomy, modified radical mastoidectomy, facial nerve decompression, and also cochlear implant. So vascular strips. So while doing tympanoplasty surgeries, this is our tympanic bone of our temporal bone. So anteriorly and posteriorly there will be two suture lines. The posterior one is tympanomastoid. The anterior one is tympanosquamous. So these suture lines will be having the bulk of the blood supply of the external auditory canal. So that's why while doing tympanoplasty, we will be elevating the tympanomeatal flap in this fashion. So while elevating the tympanomeatal flap, we should keep intact the tympanomastoid and tympanosuture lines. The flap over these two suture lines should be intact, so that the flap will be having intact blood supply. So that is the surgical importance of these two suture lines. So telling about Donaldson line. Donaldson line is actually a line drawn from the horizontal semicircular canal. So horizontal semicircular canal. So it is a line drawn underneath the horizontal semicircular, but it will bisect the posterior semicircular canal into two. So bisecting the posterior semicircular canal into two is the surgical landmark for identifying the endolymphatic sac. So these type of things are helpful in endolymphatic sac decompression surgeries for Meniere's disease, and also translabyrinthine approach. Also, when we are approaching the inner ear, we can reach the inner ear through the Donaldson line. Okay, then telling about Trotman's triangle. Trotman's triangle is an important surgical landmark for entering into the posterior cranial fossa. So posterior cranial fossa, there can be few tumors in posterior cranial fossa that we need to operate upon. So for identifying the posterior cranial fossa, the Trotman's triangle is used. The Trotman's triangle, superiorly superior petrosal sinus, posteriorly sigmoid sinus, anteriorly semicircular canals. So this is the Trotman's triangle. The Trotman's triangle, after reaching the mastoid, from the mastoid cavity, if we are trying to reach the posterior cranial fossa, this triangle will be useful. So there are few other surgical landmarks and surgical importance, but that can be dealt only after clear understanding about the anatomy of the temporal bone. We have seen about the development of temporal bone as well as a few surgical significance of that development as well. Thank you.